To introduce our speakers, Dr. Steve Peterson is a graduate of the University of Cincinnati College of Medicine. He completed his training in general surgery and cardiothoracic surgery from the State University of New York in Buffalo. He most recently worked as medical director of cardiac surgery at Flagstaff Memorial Center's Heart and Vascular Center of Northern Arizona. He is board certified in thoracic surgery. He's been with Norton Healthcare since 2014 and has the following relevant relationship to disclose. He is a consultant with AtriCure. His relationship has been successfully mitigated. Also today on our speaker panel is Dr. Kent Morris, who earned his medical degree from Southern Illinois University School of Medicine in Springfield and completed his internal medicine residency there. He completed a fellowship in cardiovascular disease and clinical cardiac electrophysiology at St. Vincent Hospital, the CARE Group in Indianapolis. He is board certified in internal medicine, cardiology, and electrophysiology. He has the following relevant relationships to disclose. He is a consultant and speaker with AtriCure. He is a consultant for Medtronic and a consultant for Biosense Webster. These relationships have been successfully mitigated. Thank you for joining us today, Kent and Steve. So without further ado, I will turn it over to you and get my mug off the screen.
Good afternoon, everyone. Happy to be with you this afternoon to have a discussion about atrial fibrillation and in particular, long-standing persistent atrial fibrillation. We're going to briefly go over the classifications of atrial fibrillation, make sure that we're able to recognize the clinical presentation of long-standing persistent atrial fibrillation, review the need for advanced therapies for this. We're going to go over the basics of hybrid ablation, and then have a few clinical cases to go over as well today. So just to sort of level set with everyone, the definitions, because these terms get used and sometimes used interchangeably. So just to be clear, paroxysmal atrial fibrillation is defined as self-limiting and typically less than 7 days, and patients convert spontaneously back to normal rhythm. Persistent atrial fibrillation is atrial fibrillation that lasts longer than 7 days or requires some sort of intervention to restore normal sinus rhythm. Long-standing persistent atrial fibrillation is defined as continuous atrial fibrillation for greater than 1 year in duration. And then finally, permanent atrial fibrillation is just defined clinically by the fact that we've no longer going to make attempts to restore sinus rhythm. Often you'll hear the term chronic atrial fibrillation. That's an older term that still gets used frequently, but really doesn't fit into the current classification. As I'm sure all of you are aware, AF is a serious and growing problem in this country. Over 1 million cases of AF diagnosed annually. Does carry with it a significantly increased risk of stroke, as well as an increased risk of heart failure, and unaddressed certainly can lead to an increase in mortality. 8 million patients, over 8 million patients in the United States with atrial fibrillation. And if you look and divide that up into the classifications we discussed, that long-standing persistent population is really a pretty significant number of those patients. I think it's really important to understand how these patients present differently than the paroxysmal patients. Paroxysmal patients, often the classic, heart beating out of my chest, palpitations, fluttering, that sort of thing, tend to be very acutely symptomatic. And patients with long-standing persistent atrial fibrillation, they tend to have somewhat more vague symptoms, though not necessarily less severe. but things like fatigue, exertional intolerance, shortness of breath with exertion, decreased energy levels. They can still have palpitations at time, but typically the symptoms are more of these other sorts of things like the fatigue, decreased energy, weakness. And because these symptoms are not specific to longstanding AFib, they can often get blamed on a myriad of other things. So I think it's important to think about this when you have patients with those symptoms. We won't go through this whole slide, but I just put this up to demonstrate, the number of different comorbid conditions that can be associated with longstanding AFib. We spend a lot of time talking about things that the patient can impact, things like sleep apnea, making sure that their blood pressure is controlled, reducing alcohol consumption, increasing physical activity and weight loss, because those things are critically important to long-term rhythm control and symptom control. This patient population has a significant impact on the quality of life for these patients. On average, over a little over a year period, these patients make several trips to the emergency department, numerous outpatient visits to the clinic or the hospital system, and a number of visits to the physicians. And so significant reductions in quality of life, as well as burden to the healthcare system. Almost 500,000 hospitalizations with AFib as a primary diagnosis, and another 500,000 of ED visits yearly. An estimated cost to the US healthcare system of $26 billion per year. So not a small number, not a small patient population to address. So when we talk about atrial fibrillation, catheter ablation really has become a mainstay for the treatment of symptomatic atrial fibrillation that has not responded to antiarrhythmic medications over the last 20 or so years. The primary approach we use is what's called pulmonary vein isolation. The problem with this approach, though, is it really is not adequate for this long-standing, persistent population. And the reason that is, in the paroxysmal patient, those patients that are early on in the AFib process, the driving factor for that is pulmonary vein triggers. And you see down in the bottom left panel, that's a 3D electroanatomic map from the electrophysiology lab. And the little red nubs sticking out, those are the pulmonary veins, and the red in that picture represents the electrical silence, and the purple indicates normal signals. And so by electrically isolating those pulmonary veins, we can disconnect those triggers from the rest of the heart. The problem is AFib progresses from paroxysmal to more persistent and long-standing persistent, that other parts of the heart become more important in driving that AFib process. So this just sort of illustrates the different factors here, things like the ligament or the vein of Marshall, ganglionic plexi in the posterior wall, reentrant rotors in the posterior wall, as well as various triggers, as illustrated by the green stars. So, in summary, in this part, that pulmonary vein isolation really is not enough in this more advanced atrial fibrillation patient population. There are a number of different techniques that we have tried in the EP lab, including ablation of triggers outside of the pulmonary veins, ablation on the posterior wall, electrical isolation of the left atrial appendage. But there's not been data to support one combination being superior over another. And this panel just illustrates that fact. A little bit busy, but the panel on the right, the blue bars show with a single ablation procedure, pulmonary vein isolation, or PVI, is that initial approach. And then each blue bar to the right of that represents various combinations. And as you can see, there's really not any other combination that has been shown to be superior to pulmonary vein isolation alone. And so that really is what's led to us to the development of our hybrid AFib program. Steve?
Thanks. Good afternoon, you guys. I'm Steve Peterson, one of the cardiac surgeons. I'd like to thank you guys for sharing your lunch with us today. So what I'm going to kind of touch base on is how we kind of developed this program and some of the basics and where we get the scientific background for it. So Dr. Cox is a cardiac surgeon from St. Louis. He was the one who first, back in the 1980s, developed what we consider the gold standard. And the procedure was actually called a Cox-Maze 4, but what he did was open heart surgery. He would make a bunch of cuts in the posterior wall of the left atrium and basically separate the heart into multiple pieces and then sew it all back together again, with the thought being that once you create that scar tissue, you really prevent the electrical activity from being able to jump that scar, thus isolating that tissue from the normal conductive pathway and hopefully giving the patient the best chance of maintaining sinus rhythm. It's a great operation. It works wonderful. It's just very technically challenging, and there are not a lot of people who can duplicate Dr. Cox's work. Since that time, we've developed more techniques and with different energy sources to try to replicate what Dr. Cox was able to do in the operating room, and preferably trying to do it with a minimally invasive approach. So the goal of our hybrid program is to basically piggyback on a procedure that was developed probably about 10 years ago, where we would do bilateral thoracoscopy and using a combination of energy sources, try to recreate the same lines that Dr. Cox was creating through open heart surgery. We've now advanced it to the point where instead of doing a more complicated, minimally invasive procedure, using the combination of both what Dr. Morris can do endocardially and what we can do epicardially, we've been able to advance our program. So using a hybrid ablation, my part of it is we do a subxiphoid approach to ablate the posterior wall, and then through a left thoracoscopy approach, we occlude the left atrial appendage, and then also at this point now are also creating extra epicardial burns, dividing the ligament of Marshall, as Dr. Morris mentioned earlier. Do I advance the slides, or are you? There we go. So the hybrid procedure, as I described, through a subxiphoid approach, we can get to the left posterior wall of the left atrium. And as you can look in that first panel, that skinny catheter has suction cups built into it, so that we can, using the 5mm endoscope, we can position it where we want it on the posterior wall of the left atrium, suction it to the back of the heart, and then we run current through it for 90 seconds. That current allows us to create that ablation burn that you can see in the picture. It looks like railroads. Essentially, we visualize both the left pulmonary veins and the right pulmonary veins, so that we continue to, march that catheter all the way across and basically create a square of ablated tissue. We go to the roof as far as we can, where we run into the reflections, and then we go to the floor about where the coronary sinus crosses and divides the left atrium from the ventricle. Once we get that part done, then obviously 6 to 12 weeks later, Dr. Morris brings them back and does the endocardial portion of the procedure, which we'll describe a little bit later. The nice thing about us for the epicardial portion, one of the things that we can get to a little bit better is the area of the posterior wall of the left atrium that overlies the esophagus. And since our energy is going from outside of the heart inside, our risk of injuring the esophagus is a lot lower. We also use a temperature probe within the esophagus to make sure that we're not creating any extra heat injury to the esophagus as we're working. So we make a standard subxiphoid incision, as you can see in that top picture. We usually end up excising the xiphoid process itself just to give us a little extra room. We make a transverse incision across the pericardium, and then using a cannula, we can advance the catheter and the camera safely underneath the heart along the diaphragmatic surface so that and the posterior wall of the pericardium to visualize the anatomy and create our burns. As we'll talk about a little bit later, one of, I think, the biggest benefit of this procedure is not only to be able to get a better burn involving the posterior wall of the left atrium, but we can occlude the left atrial appendage. As we know, that's where the majority of strokes come from for patients who are in atrial fibrillation. So if we can take the left atrial appendage out of circulation, in theory, if the blood can't get in, then the clots can't get out so that we can protect them from having strokes. The second benefit of this is because the clip occludes the left atrial appendage, it also makes it ischemic, so we can shrink the left atrial appendage from scarring. That scar tissue also interrupts a motor that circles around the base of the left atrial appendage that is somewhat difficult to get to from an endocardial approach. So for us, I think it gives us, we get kind of two bangs out of that buck. We can hopefully prevent them from having strokes in the future, and in theory, come off their anticoagulation at some point down the road. And we also interrupt another pathway. So these are just some slides, some stills to show the different shapes of the left atrial appendage. So we can see some that look like chicken wings. We see some that, like in that first picture. And then we kind of see that big broad base that is probably the most common all the way on the right side. But as you can see in these pictures, we open up the pericardium. We open up the pericardium just beneath the phrenic nerve, so we're careful to avoid damaging that. One of the nice things is we've gotten more experience with this. We can identify the ligament of Marshall, and we can divide that using bipolar cautery so that's one more pathway that's interrupted. And with our experience now, there's our picture of ligament of Marshall. And with our experience, we've done over 100 of these cases now, and we've extended our lesion set to come up around the anterior surface of the pulmonary veins on the left. And also now using our insense catheter, we can actually extend those burns across the Coumadin ridge onto the dome of the left atrium, so that hopefully we can actually make Dr. Morris's and the other electrophysiologists' jobs a little bit easier by creating a little more epicardial burn. So this is a still pictures from an intraoperative echo. And on the first before, you can see that left AA stands for the left atrial appendage, that LCX stands for the left circumflex artery, which is very close by. LA stands for the majority of the left atrium. And then left SPV is the left superior pulmonary vein. And so those are sort of our boundaries of what we're looking for and what the anesthesiologist, as we're doing the intraoperative echo, is looking for, and our landmarks to make sure that when we occlude the left atrial appendage, we're not impinging primarily on the left circumflex, but we're also making sure that we're not leaving anything behind. So the nice thing with this clip is that it is, we can open and close it without deploying it. So if we have the tissue there and we close it, the anesthesiologist says, hey, listen, you still have a residual stump. We can open it back up. We can pull more of that appendage up into the clip to make sure that we have it all, close it again. And once we're happy that both from an external view through the camera and as well as internally through the TEE, to make sure that we have the entire appendage up into that clip before we fire it and deploy it. So, importantly, a poorly placed clip is actually more dangerous for the patient than leaving it alone. So if we get to the point where we feel that we can't get all of the appendage in there because we're impacting the circumflex artery, or because his anatomy isn't appropriate for getting that clip on, we'll just back out, and if necessary, he can go for a Watchman device or something else if we need to take out the left atrial appendage. But we'd rather not put a clip on than put a poorly placed clip. And I think Dr. Morris will agree with that.
Absolutely.
So this is a quick slide that talks about how the FDA looked at this program and finally got approval. So there was quite a few sites within both US and UK that were looking at doing a hybrid program arm versus just a endocardial ablation arm. And as you can see, that the results were very favorable for patients who went for a hybrid conversion versus just an isolated endocardial approach, which I think correlates fairly well with the data that Dr. Morris was talking about in the beginning of this talk. 18-month outcomes, you can see that there's quite a bit of difference between freedom from arrhythmias. 68% of these patients were doing better and staying and maintaining sinus rhythm than isolated endocardial approach. Next slide. So what did we accomplish here? Kent, you want to do this part?
Yeah, I thought it would be useful just to understand the process of a patient going through a hybrid ablation, and so just the experience here, we have a core group that meets monthly. We discuss patients, we discuss them both prospectively as well as, case review after the fact. So frequently we'll talk about patients to make sure we have the best treatment plan in place, and then we'll review that after the fact to make sure that we've accomplished what we set out to do. We also use that meeting to discuss any modifications or advancement of the program, whether it's protocols or best practices. Patients are identified. The patients that are identified do tend to be persistent or longstanding persistent atrial fibrillation patients, tend to be patients with moderate to severe left atrial enlargement. You look at the left atrial volume index, which is an echocardiographic measurement. Some of these patients have had endocardial ablations and failed. Some of them have not had prior ablations. The big contraindication would be a prior sternotomy. Once the patients have been identified, they're sent to see Dr. Peterson. They get appropriate workup, including an ischemic evaluation and echocardiogram to look for any sort of valvular heart disease or coronary disease that would suggest that they might need something more than just a hybrid procedure. We have a coordinator that helps move patients through this process. Dr. Peterson described the surgical portion, typically a couple of days in the hospital or so with warfarin anticoagulation afterwards, just to minimize the risk of rebleeding postoperatively. They'll see Dr. Peterson several weeks after the procedure. They'll typically be seen in the EP clinic about 6 weeks after, at which point we typically would set them up for their endocardial procedure. At about 6 to 12 weeks after the surgical portion, we would take them in for a catheter ablation. The catheter procedure would involve a high density electroanatomic voltage map of the left atrium. And we can see in those maps, and you'll see in the cases, we can see largely what's been done on the posterior wall. And then we can complete the pulmonary vein isolation in addition to any other ablation that might need to be done, as well as testing for any other sort of problem areas. And then they remain on anticoagulation for a minimum of 3 months after their endocardial procedure, at which point we often have a discussion with them about the pros and cons of coming off of anticoagulation, assuming that a clip was successfully placed on the left atrial appendage. Did you want to talk about the program numbers to date, Steve?
Yeah, so this is a while ago. So at this point now, I think we have close to 120 patients that we have completed. As a matter of fact, I saw 2 of them post-operatively today who just had completed their first stage. One was a de novo patient. The other one was someone who had 2 prior ablations that failed. Both of them this morning were still in sinus rhythm and doing quite well and feeling well. So I think we've done about 120 roughly. We have, I think the most recent data shows that we have our success rate right now is in close to 80% for 1 year remaining in sinus rhythm. We have a fair portion now that are off their antiarrhythmics and additionally are off their anticoagulation. So I feel, I think the nice thing is that these patients in general in the past wouldn't have really had any other good options. As Dr. Morris pointed out, most of these people are fairly large, have high BMIs. They have sleep apnea. They usually have at least left atrial enlargement, usually biatrial enlargement. And we know historically, these are the patients that would fail just isolated pulmonary veins or, have clearly failed medical management at this point. And this is something that, 5 years ago, 10 years ago, we really didn't have to offer folks. And I think it's been kind of a game changer as far as being able to make people return to their quality of life and improve the way they feel.
And I would agree with that. I mean, in the past, a lot of these patients would have been patients that we would have either offered a catheter-only ablation, but with a much more modest expected success rate, or we just would not have had a great option for treating them. So we have some case studies to go through and then see if anybody has any questions. So case number 1 is a 70-year-old female with a history of hypertension and prior vasovagal syncope, as well as thyroid disease, sleep apnea, and hyperlipidemia. This patient was admitted February of 21 for dyspnea and was found at that time to have atrial fibrillation and some rapid rates. The patient underwent cardioversion but had early recurrence of AFib, was started on antiarrhythmic medication with repeat cardioversion, further had nuclear stress testing and echocardiography that both looked okay. Very shortly later, the patient was readmitted and was noted to have severe dyspnea. A repeat echo at that time showed a fairly dramatic drop in the ejection fraction, and it was felt to possibly be consistent with a stress cardiomyopathy. Flecainide is an antiarrhythmic medication that's contraindicated in patients with LV dysfunction, and so that was stopped. The patient was placed temporarily on a life vest for bridging, hopefully to recovery, and started on amiodarone. The patient did have nausea on amiodarone, which is a not uncommon side effect. The patient was also started on guideline-directed medical therapy. However, the nausea did not get better, and ultimately the patient stopped this because of severe nausea related to amiodarone. Patient was seen in AFib clinic a couple of months later, and given the significant drop in ejection fraction along with severe left atrial enlargement, it was decided that the hybrid ablation program would be good for this patient. Had the first stage of their procedure and had posterior wall ablation, as well as ligament of Marshall excision and placement of a clip on the left atrial appendage. At 6 weeks follow-up after the first portion of the procedure, the patient was still maintaining sinus rhythm, was already off of antiarrhythmic medications, and the ejection fraction had already returned to the normal range. We did go ahead and complete the second portion of the procedure. Patient also did well with that and has continued to remain in sinus rhythm. Try to explain some of the pictures here you're looking at. And I think it'll probably be easiest if we focus on the top two panels. So if we start on the top left, we're looking at the posterior wall of the left atrium. Again, red, the red color represents scar tissue or electrically silent tissue, and the purple color represents normal signal in the left atrium. And you can see on the pulmonary veins sort of sticking out to the top and bottom right of that picture and over to the left. And so that top left picture is the result of the posterior wall ablation by Dr. Peterson. And then the image to the right is after their endocardial procedure, and you can see where now the pulmonary veins, instead of having some purple or normal signal, the pulmonary veins as well as the posterior wall are electrically isolated. So this patient had a good outcome both from an electrical standpoint as well as maintaining sinus rhythm and ejection fraction returning to normal.
So the second patient is another lady who was 64 years old with fatigue, and exertional intolerance. She had had prior cardioversion, which failed, and she had been treated with amiodarone and was hypertensive and had a myotonic dystrophy and obesity. She was seen in AFib clinic. She was attempted again for cardioversion. They bumped up her amio. She unfortunately failed again and was then sent for surgical evaluation. So we were able to take her to the operating room in May of 2021. We did standard hybrid ablation. We were able to get a clip on for left atrial occlusion. She maintained sinus rhythm and then was taken for her second stage on 2021, where Dr. Thomas completed her pulmonary vein isolation, touched up her left atrial roof line, and then did a line in the right atrium as well to interrupt any signals over there. She was able to come off her amiodarone, and much later, she's still in sinus rhythm and feels significantly better. So I'll let Ken, why don't you go through these maps?
Yeah, so this is more my language than yours, huh? But so this is, again, these are labeled pre and post, but I think, just if they're really sort of the same. So we're looking at the posterior wall of the left atrium again, and you can see on the left, the pulmonary veins are sort of the extensions and sort of the four corners, if you will. And so there's still some signals, and some of those you can see along the posterior wall, which in this view is actually sort of the top of that image. There's a lot of red, so that's good because that means Dr. Peterson was able to ablate a lot of that area. And then there's just a little bit of purple sort of in the middle, which is actually the roof or the top of the left atrium. And then on the right view, you can see that the pulmonary veins that are extending out, there's no longer any electrical signals. So that's good. That means those veins are isolated. And then talked about that touching up that roof line, which means that some of those sort of splotchy signals in the top of the left atrium now have been isolated along with the posterior wall. And so once again, a good electrical outcome, and the patient, maintaining sinus rhythm.
Yeah, I think one of the, can you go back one slide? One of the things to keep in mind is the roof line for us epicardially, we are somewhat limited by the pericardial reflections. And I don't know if we have a picture of it coming up, but the pericardial reflections, sometimes they look like a peak for a roof. Sometimes they're very broad. And if they've had prior ablations or anything, we're kind of limited sometimes with scar tissue about how much and how high we can get. So we try to be really good about trying to get as tight to those veins as possible. But it's very common that sometimes where we can get to what we think is a roof line looks completely different endocardially from what we see epicardially. So I think, part of the nice thing about having a hybrid program and a multi-specialty is that, again, there's this nice teamwork where we get what we can get, but, we make sure that the goal is to make that unit of pulmonary veins, posterior wall, left atrium are electrically silent to give that patient the best chance of long-term sinus rhythm.
Yeah, that's right. And the roof line for us in the EP lab is one of the easier lines, for us to complete. So that works out well. Case number 3, 62-year-old man, persistent atrial fibrillation, hypertension, sleep apnea that's treated. And again, you see sleep apnea coming up again and again. It's very common association with atrial fibrillation, and critically important that patients treat that. Really all comorbidities, but particularly sleep apnea. Had failed multiple antiarrhythmic medications, so both flecainide, propafenone, and dofetilide. No prior ablation, but patient was having exertional intolerance, fatigue, dyspnea on exertion. So again, going back to that presentation, some of those sort of little bit more vague, but persistent symptoms rather than the classic, heart beating out of my chest. Rate control was not ideal, and also saw some decrease in the ejection fraction, at least moderate left atrial enlargement. And so, here we're looking at a patient with, persistent symptoms, falling ejection fraction, moderate, at least moderate left atrial enlargement. And this becomes the type of patient that I think is well served with hybrid ablation. Again, able to take the patient to the OR, do the standard lesion set with the clip on the left atrium. This patient did remain in atrial fibrillation postoperatively. And for patients that have not had a prior ablation, and the hybrid is their first ablation attempt, this is not uncommon. And both Dr. Peterson and I make sure that we take the time to explain to patients that, if you stay in AFib after the first portion, that's actually okay. That the procedure isn't complete until we do the second portion, and that's most definitely not considered a failure. Part of the hybrid approach is that part of the lesion set is done in each procedure. And so some patients, like you saw in the first case, some patients do maintain sinus after that first procedure. However, the situation in this case where the patient does not maintain sinus is not uncommon, and that's okay. The patient was loaded on oral amiodarone. Did have a little bit of delay in completing the second portion of the procedure. And despite better rate control, the ejection fraction dropped further, which is not rare to see in patients with AFib like this. The endocardial lesion set was continued. Amiodarone was continued, and the patient, here's our endocardial maps, and this is a pretty good map. And again, on the left is after the first portion of the procedure, and Dr. Peterson mentioned that picture of the pericardial reflections, and really it would mirror exactly what you see in this endocardial map, where you get almost to the roof, and then the gray line going down the middle is actually we've actually drawn in, based on intracardiac echocardiogram, we've drawn in a tracing of the esophagus, is what that represents. And so then you move on to the right image, and we have added in the endocardial ablation connecting to the prior posterior wall ablation, and the veins have been isolated at this point. So after the second stage, the patient did stay in sinus rhythm, and that's because we've now completed the lesion set. And 3 months post ablation, the patient's ejection fraction did improve up to the normal to low normal range. And at 9 months after the second stage, we were able to taper off their amiodarone, and the patient did continue to remain in sinus rhythm.
So I think this is our last case study. 64-year-old gentleman who had a non-ischemic cardiomyopathy, persistent atrial fibrillation, hypertension, diabetes, and again, sleep apnea. He had been cardioverted once and could not maintain sinus rhythm. He failed medical management. He had no prior ablations, and he had the usual symptoms that we hear of with fatigue, again, exertional intolerance. And I think, one of the things that Dr. Morris has mentioned, from a surgical standpoint, it is sometimes very difficult to weed out what's truly from his atrial fibrillation. Is this ischemic disease? Is this, does he have mitral regurg or some other reason why he still feels poorly? One of the nice things is that if they have been able to get cardioverted and are tolerate sinus rhythm for a while, very commonly I'll get the, Dr. Peterson, when I got the shocked, and man, I was in sinus rhythm for 3 days a week. That was the best three to 7 days that I've had in a year and a half. I felt wonderful. I felt like back to my old self. And as soon as I converted, I could tell immediately because I felt terrible. So, for me, that's a good sign, because then I know if we can get them in sinus rhythm, that we're going to help improve their quality of life. If they tell me that they don't feel that much better when they're in sinus, I really, really push them towards getting some sort of ischemic workup, because those are the people that we have found have concomitant coronary disease and end up going for open heart surgery to get a CABG maze versus just an isolated hyper. Anyway, so this patient also had severe left atrial enlargement, which is common. His ejection fraction also was decreased. Can we advance the slide?
Sorry about that.
So he had his first stage in 2018, and just for reference, we've actually been doing these surgeries, I believe, since 2017. So we almost have a 5-year experience at this point. He got our epicardial ablation of the posterior wall. He was a very large gentleman, and so those are the guys that sometimes we have issues with single lung ventilation. So we weren't able to complete to put a clip on to prevent him from so we didn't get left atrial occlusion. He did remain in AF after his first stage as expected. He had some issues with some Dressler's type syndrome where he was getting some parapneumonic effusions and ended up needing decortication. He got his second stage done in February of 2019, which is a little bit longer than we like, but with these other issues, he was kind of back and forth in the hospital. He did end up getting his vein isolation touched up his left roof line. Once we got that, they then noted that he also had an atypical flutter, so they were able to ablate that as well, which Ken can speak to that, but it's not uncommon that they sometimes find other rhythm issues. Once they get the fibs slowed down and settled out, all of a sudden they can start picking up flutter lines, which also they can take care of. He was started on his amiodarone. And again, you can see the map on this gentleman. When I always look at it, it always reminds me that it looks like Russia, whether it's all red and it kind of looks like, so that's what I look for. You can see that as there was a part there, but on the post, you can see just what Dr. Morris has described. Posterior wall of the left atrium is electrically isolated. Pulmonary veins are electrically isolated. And hopefully this patient has been maintaining sinus rhythm, and his EF is back to close to normal again.
So I think that just gives you a little bit of picture of this patient population and some of the sort of newer therapies here. The posterior wall is important in these patients. Studies have validated this, including the randomized controlled trial at Converge that we touched on. I think important parts of this is the multi-specialty, the multidisciplinary approach is really critical to the success of this, and allows us to really treat a patient population here that did not have good options in the past. With that, I think we have a few minutes for questions if there are any.
Yeah, we actually got one question that's already in the Q&A that I'll go ahead and give you. And then I wrote down a couple if we don't get any more in the Q&A. So the participant question is really about nomenclature. So how would you describe some the patients that often we see that are just flipping back and forth between sinus rhythm and AFib? Is that someone that would fit in that paroxysmal definition?
Yes, that would be true. They're not called persistent until they reach 7 days of continuous. And then, myself, being an EP, if they're in that sort of first few weeks of persistent, I tend to call them early persistent. And then the long-standing persistent is, again, once we hit a year, which is the people that have been persistent, or especially that long-standing persistent is really, the patient population that most benefit from a strategy like this.
And then the questions that I wrote down really have to do with, I know we don't live in an ideal world, but what would you describe as the ideal patient for this process?
Well, I think Dr. Morris and I have different definitions of ideal. But with all joking aside, I think the patient that clearly does the best is someone who has a BMI that's probably greater than 35, that has left atrial enlargement, sleep apnea. They're usually diabetic. Patients that, the feeling is that are long-standing persistent or at least persistent. I think this operation is great for people under BMIs at 35. I would love to see more of those, believe me. But the reality is that the people that are larger are more likely to have long-standing persistent and more likely to fail either medical management or pulmonary vein isolation alone. So
that leads into my other question, which this does seem to me like, just based on everything, like all the cases that you presented and the initial information, that these are much higher risk patients than just clinically higher risk for just about every comorbidity, et cetera. So let's say it's someone like me who is otherwise relatively healthy, happens to flip into AFib and stays there. So what are my treatment options compared to this higher risk population?
You want to take that one, Kent?
Yeah, I think that those younger, healthier patients that have had less AFib, especially the paroxysmals or the what I call early persistence, probably well served by a catheter ablation only. With the paroxysmals in particular, we do a pretty good job with the catheter procedure. And it is a little easier, simpler approach. I think the real benefit of the hybrid approach is those patients that really have been in AFib more. They have those vague symptoms, and so nobody's really sort of recognized, oh, hey, you're in AFib, until the point that they have a moderate or severely enlarged left atrium, and maybe their ejection fraction is affected. And those patients, tend to have much more modest success rates with a catheter-only procedure. And so I think that's where the strength of the hybrid program, is where we can, really offer those patients a much more successful approach by doing this combined procedure. Does that make sense?
Yes.
Right. I think to add to that, yes, these people have a lot of comorbidities. I think this approach compared to an open heart surgery certainly is, we kind of minimize their risks as much as possible. A subxiphoid incision is very well tolerated. It's not very complicated from a surgical standpoint. The left atrial appendage, left VATS, we're making small incisions. And so, from a surgical standpoint, from the large, vast patients that we, adult acquired disease, these patients are, yes, they are sicker, but they're not as sick as some of the normal patients that we get. And so we've had very pleased with how well most patients do with this procedure. The first, as you can imagine, the first little bit is rough from a pain management standpoint, but the anesthesiologists are great about putting in rib blocks or paravertebral blocks so that they're relatively comfortable the night before. We haven't really touched on some of that, but we usually treat them with some sort of non-steroidals to help with their pain management. Once we get the chest tube out, most of them are up and walking. In general, we have them discharged within 2 days to kind of make sure that we don't run with issues of recurrent effusions or esophageal injury. I usually treat these patients with a short course of steroids. We just send them home with the Medrol dose pack. The other thing we didn't really touch base on, but as far as the anticoagulation goes, as Dr. Moore said, touched briefly, we do switch them to Coumadin. We start that the night of surgery. And by the time Dr. Moore sees them and gets the second stage, they've either been reconverted back to their 10A inhibitor prior to the second stage, or as soon as the second stage is completed, they go back on their 10A inhibitor. So I warn patients in advance, this is what we're doing. Because you can imagine most people don't want to be on Coumadin after they've been on a 10A. But once you explain to them, it's easier than having to go back to the operating room for drainage of a bloody effusion. Most times they're pretty okay with it. So, I think we've been very pleased with the how well most of these patients have really come through the first stage to get them ready for the second stage.
So is there a point in the decision tree where you branch off and there's a subset that you're looking more for just a Watchman on, and then a subset that you're looking at this procedure on?
Yeah, I mean, I think the Watchman, really would be for those patients that they're not symptomatic or not very symptomatic with their AFib, and more, issues with bleeding or wanting to be off of the blood thinner. And I think the patients that, benefit most from the hybrid procedures, the patients that, are really pretty symptomatic. And so I think that would be the key differentiator, I think, in making that decision is the degree of symptoms. We're not going to address symptoms at all with a Watchman procedure, but hopefully we're going to keep you in rhythm and improve your symptoms significantly with the hybrid.